Thanks very much. So worldwide, we know that levels of obesity and patients with large arm circumference, that very high prevalence, particularly in developed countries, means it's a significant proportion of patients that are not suitable for measurement with a standard cuff. In that case, guidelines often recommend using a larger cuff, or in more extreme circumstances, a forearm cuff or a wrist cuff. Yet if you look at the major guideline developers, such as the American Heart Association, they recommend that it's acceptable to use a wrist cuff. The European Society of Cardiology says not to use a wrist cuff, and the British Hypertension Society kind of sits on the fence a little bit and says there's some uncertainty. So it's all a bit confusing, and that's around to the status of the evidence as it stands at the moment. So we thought we'd do a review to kind of sort this mess out a little bit. So it's a diagnostic accuracy review, so a fairly standard diagnostic accuracy review methodology. So searching through the major databases, looking for cross-sectional, randomised trials and cohort studies of diagnostic test accuracy. And we're specifically looking for adults who both had a large arm circumference of greater than or equal to 35 centimetres and a BMI greater than 30. We also did some subgroup analysis with slightly larger subgroups as well. They were independently reviewed by 3 reviewers using the Quad S2 criteria, which is an indicator of the quality of the studies. And we made multiple comparisons. So this is where it might deviate a little bit from a standard diagnostic accuracy review, because we looked at multiple reference tests and multiple index tests. So our reference tests were invasive blood pressure, a fitted upper arm cuff, and ambulatory blood pressure monitoring. The index tests were upper arm, forearm, and wrist cuff, and the upper arm was just with a standard cuff. So these were the main findings. So there was quite a lot of gaps in the comparisons that we made, but the ones that we did find. So if you, just for reassurance, if you can compare invasive with a correctly fitting cuff, that had an area under the curve of 0.88 and had reasonable sensitivity and specificity. If we switch our reference test to a correctly fitting cuff, well, if you look at the area under the curve for those, the wrist performed better than the forearm, and which in the wrist performed better than the standard cuff as well. So with that in mind, the main take-home points I would take from this is that measurements of blood pressure with a correctly fitting cuff is sufficiently sensitive and specific to diagnose hypertension in obese patients with a large arm circumference. If if a correctly fitting cuff, upper arm cuff cannot be applied or is unavailable, then a standard size cuff should not be used. There's good agreement between wrist and upper arm, and instead of blood pressure measurement at the wrist, if you need to, the measurement at the wrist is preferable to that at the forearm. So if you get stuck in clinic, don't put it on the forearm, put it on the wrist.
Questions? What people in the audience do if they get someone with their biggest calf won't fit down their arm?
I went around all the outpatient clinics in Cambridge and student GP outpatients. Everyone was doing different things. So that was my it was not particularly robust or scientific, but it was fascinating to see people using different approaches when asked.
Yeah, I tend to use a large cup, but sometimes it's not large enough.
That's the problem these days.
John Campbell from Exeter. Thanks, Greg. Just in terms of measuring blood pressure, the more I've worked with Chris Clark, the more confused I've become. In terms of, because there's so many other variables around saying what is the reference blood pressure.
Absolutely.
So all these studies, do they control for all the other variables in terms of white coat or time and resting? And
yeah, it's quite interesting when you look at I've not put it up for brevity, but if you look at the years at which this has been, these studies have been conducted, some of them are quite old, particularly the ones around invasive blood pressure. And you're quite right, if you think about the thresholds in the upper arm versus the forearm versus the wrist, there's some assumptions being made there about what that threshold should be. So one thing that was nice is we actually had some individual patient data as well.
Right.
So particularly looking at around the wrist, we were able to look to see whether it was within like British Hypertension Society reference standards for whether it's there's a significant difference there. So you could actually go back into that data and look at different thresholds and see what's there. So that data is actually available, so we could actually go back and look at that. So if there was some question around the threshold that we've adopted, then we could adjust for that.
Thank you.